Can you tell me what your thoughts are on the term shrink?
Yeah, so I've never liked that term. I think it's almost pejorative. It's like, someone calling you or making fun of you. So
Mhm.
I don't really understand where it came from. I have some guesses, but I find it to be really unhelpful in the grand scheme of things because it doesn't describe anything that we do as psychiatrists. And so it kind of drives me a little bananas.
Welcome to the second season of How Are You Really podcast, where we slow down, check in, and get real about what's going on underneath the surface. I am your host, Dr. Faryal Mallick. I am a triple boarded child, adolescent, adult, and forensic psychiatrist, and today's episode is called Not Your Shrink, Redefining Psychiatry from the Inside. Today, I'm joined by Dr. Brian J. Dixon, MD, an award-winning psychiatrist, author, and speaker who believes adaptive mental health is the foundation of a life well lived. From overcoming poverty to becoming a physician, Dr. Dixon now uses his voice to educate patients, peers, and society about income and wealth inequality through his private practice Mindful and his practice management company Simply Psych, both based in Fort Worth, Texas. In this episode, we talk about what psychiatry really is and what it definitely is not. Dr. Dixon and I get into how the field needs to evolve, what it means to truly listen to our patients, and why rethinking training and private practice could change everything. It's a conversation about showing up differently for our patients and for ourselves. Welcome, Dr. Dixon. I really
Thank you.
appreciate you for joining us. So I'm going to start with just the simplest question. How are you really doing?
Actually, I'm kind of tired. I had a really long spring, so with everything going on, just kind of nationwide, and the end of the school year, because I see kids, it was a lot. So now we're in the summer of 2025, and life is much better.
That's good. That's really good. All right. So I want to get right into our topic for today. Can you tell me what your thoughts are on the term shrink?
Yeah, so I've never liked that term. I think it's almost pejorative. It's like someone calling you or making fun of you. So
Mhm.
I don't really understand where it came from. I have some guesses, but I find it to be really unhelpful in the grand scheme of things because it doesn't describe anything that we do as psychiatrists. And so it kind of drives me a little bananas.
Yeah. So do you know the history of like where it came from, what the origins were?
Yeah, you would think I would go and research it, but it's one of those things where I'm like, I'm not going to waste a single second of my time on something that I can't control. But I think it was a nod to head shrinking, like witchcraft and sorcery and stuff like that from back in the day. But like I said, very pejorative, very like putting you down kind of thing. And so, but yeah, I'm sure there may be other sociologists that know more, but I'm just not going to spend any time on learning more.
You know, when we started that conversation, I was curious. I wanted to go look because I only thought of it like as a funny term that's been used, or some people were saying that we shrink their problems. But I was really curious. I was like, there's more behind this. So I looked it up and it's what I found. Witchcraft and old beliefs and then its relationship with lobotomy. So, what do you think the impact is? I know you said that it's down-putting, off-putting, but what do you think the impacts are overall on the perception of psychiatry and mental health professionals? How does it
Yeah.
affect us overall?
Yeah, so words have power. And I think that you've seen it in your practice, I've seen it in my practice, which is when you believe something, when you speak something, when you put it out into the universe, that energy can manifest and it can become certain things. And so when you're putting out words like shrink, which is very, constricting and small thinking, it makes everybody around that term seem less than. It is not a growth mindset as all of the as the business coaches and performance psychiatrists like to say. So, yeah, I think we need to change our image. We need to change that term. We need to retire that term so that we can build a better future for psychiatry.
Absolutely. Have you personally encountered any challenges due to the label?
So not directly, like people will make jokes like "you're my shrink," and I'm like, okay, whatever. For what it's worth, and I think I saw this in one of the groups. A lot of younger people don't really use the term. This is a an older person term,
Yeah.
probably 50, 40s, 50s, and older. So it's not holding me back, but it is something that I think we should reframe and capitalize on at this point.
Yeah, I've also noticed that none of my, even like my 30s and 40s, once you go over 50, that's where the
Mhm.
patients will kind of refer to you as their shrink.
Yep.
So I hear that completely. So it's an old term. It
Mhm.
seems like it's dying, but I do have the sense that you have a very passionate feeling just because overall the image of psychiatry has just been very negative. And so what do you think, what strategies can we use? How can we change the narrative? Like, how do
Yeah.
we fix this?
Yeah, so I've spent a lot of money with marketing agencies and learning the marketing world, which is basically how do you get your story and your image out into the universe. And so certain companies do it really well, Nike and Coca-Cola. Certain professions do it really well, like nursing and firefighters. And so the funny part is, in those particular professions, what they do is in the title of their name. Like a nurse, nursing in nurse is it's a verb. And so physician doesn't really say what we do. So what I've been doing lately is I'm working on a marketing proposal to pitch to lots of different doctors that we start calling ourselves the listen physician, right? So we are the physician that listens. That is our whole thing. We're not cracking chests and burning holes in people's heads. We are the listen physician. And I think that's a more kind of active term. So we'll see if I can get it out there into the vernacular and then get it to catch on with other psychiatrists.
Yeah, because you brought up the listen physician thing. A lot of us do practice a lot of therapy with our patients, but there are some psychiatrists that will just do medication management and they are quickly seeing patients. I feel like that's not fair because I spend a lot of time with my patients and listen. So
Hmm.
how do you feel about that?
Yeah, I tell people all the time, especially when I'm teaching medical students or residents, that good psychiatry is exhausting. So just listening and listening correctly and intensely and appropriately is exhausting. And so I don't get mad at our quote unquote psychopharmacology colleagues because honestly, I think part of it is their training. If you go to one of those training programs where all they talk about is medicine, that's all you're going to learn. So I try not to beat them up, but I will say that they're kind of missing half of the picture. And so I hope that whoever's listening to this will go, there's other ways of doing things other than just throwing the medicine at it. And that listening is our biggest skill set.
Yeah, absolutely. I have like patients that transfer over and they will say that, oh, I only used to get 10 minutes with my psychiatrist. And it's unfortunate, right? Because we're not
Mhm.
doing us ourselves any favor if we're doing that, and doing our patients any favor. I had like an older late patient, older, that's why I say older. I mean, late 40s is not that old. So, but she was misdiagnosed as ADHD. As soon as I saw her, I was like, oh, this is mania. She's manic. But I didn't diagnose her right away. We took time. And then, of course, ADHD is not the right diagnosis, but she was treated for ADHD for like 10 years before she saw me. And she was doing certain things that she finally opened up to me. I'm guessing she never told her previous psychiatrist. The things that she was doing was okay. We're in that realm. The listen physicians is like, that's so important. And if
Mhm.
we don't say that, people don't understand.
Correct. Yeah. Because as of right now, yeah, if we just say, oh, we're psychiatrists, again, most people know what a psychiatrist is. But if you say, no, I'm the listen physician, people go, oh, okay, this is cool. So.
Yeah, yeah. And I wonder how many people actually understand what a physician is either.
Yeah, so good question. So it's really funny. And again, this is where you may get hate mail. So I don't mind if other people who get a terminal degree, a doctorate, calls themselves doctor. I don't mind that at all. So psychologists or PhDs or PsyDs or EDDs, they can call themselves doctor because they earned it. And so one of the reasons why I didn't choose listen doctor is because it's not specific enough to us. So yes, so even though physician, some people may not quite know that term. I'm hoping that we can kind of re-own it in a
Yeah.
sense, especially if we put the listen in front of it. So we'll see.
Yeah. Yeah. Hopefully. I feel the same way. But I do wish that people would make it clear that they're not a medical doctor because it gets
Mhm.
very confusing. And sometimes I get mad at our own profession that why didn't we choose to call ourselves doctor? PhDs came first, so they get to keep the doctor. We should have been called something else because it's just very confusing.
It is very confusing. I completely agree. Yep.
So we want to help. I want to help, and that's why I reached out to you. So how do you think we can all like combine effort to help you
As
change
a
this terminology?
Yeah, so one of the I did a consult a long time ago to talk about marketing and kind of wide scale marketing nationwide, and I went with this agency, and they said basically if you want to get any type of traction, you have to hit people 8 to 15 times with a concept before they'll go, oh, this is really interesting. And so to have that many touches, that many marketing touches, that many exposures is going to take millions of dollars to do that and in a concerted effort. So I don't know that I can do all of that. However, what I can do is talk to us. So psychiatrists know other psychiatrists. I would love for people to hear this podcast. I would love for us to start teaching residents and fellows about this concept. I would love if organized psychiatric medicine, so APA, the ACAP, all those folks took up that call, took up that hashtag to start using that, because at the end of the day, it's going to take concerted recycling of that term again and again and again before people start to like catch on.
Yeah. One of the things that I also did was I looked up the actual meaning of psychiatrist and came up per dictionary, it's healer of the mind. So I thought that was really cool too. But again, that like, then how do you still differentiate between a psychologist and a psychiatrist, right? Because that's
Yep.
such a huge confusion right there.
Mhm.
The people think that I'm their psychologist and you have to
Mhm.
explain the difference. So there's a lot of issues with the term psychiatrist, not just one,
Yep.
right?
You're
Like
100% correct.
ophthalmologists, those are physicians, but psychologists are not. So,
Yep.
we kind of chose the words and alphabets quite incorrectly, I feel like.
Yeah, and it was one of those things where, had we had the foresight to know that social media and, managed care and insurances would do what it did and has changed our industry up under us, they have
Right, right.
changed terms around us, I would have said, yes, choose a better name. But, we are where we are now. And with TikTok being TikTok and all the things and, people trying to control our narrative, I was like, no, I don't want that to happen. I want to reclaim our space.
Absolutely. How do you feel about the term mental health professional?
Yeah, so I don't mind it. It is a point of contention. I hate the word provider because to me, a provider is a mom or a dad, right? It's a parent. I'm providing food, shelter, clothing, love, blah, blah, blah. So I don't like the term provider. I do like the term clinician. So if I am speaking about the broad number of people in the health space, I call them clinicians. Mental health professional, I mean, it doesn't bother me. I think the term mental health is pretty bland and vanilla and non-threatening, so I go with it most times. I don't
Yeah.
push back against it.
There was, I think, a discussion about that too, like shifting from psychiatry to it being called mental health. And some people had like feelings about that.
Yeah, no, no. Let me be very clear about that part. Absolutely not. I will never, do not ever call me a mental health professional. You can call me a psychiatrist who is a mental health professional. That works, but no.
Mm,
Yeah, it cannot replace, mental health professional cannot replace the actual licensure and certification.
absolutely. We earned it. Worked very hard. So, how has your journey as a psychiatrist shaped your ideas of all of this? Just mental health care, psychiatry, psychology, and our place in all of what we're in right now.
Yeah. So it was really funny when I first got into medical school. I thought I was going to be a family medicine doctor until I did that rotation and I hated it. And it was awful because it was so fast. I don't think that fast. I don't like to go from room to room and try to like fix the world's problems or that person's problems in 5 to 10 minutes. That's just not me. And so when I did my psychiatry rotation, we had a lot more time. And so I love the idea that good things take time. So, and then psychiatry just proved it because if I rush into a situation and I don't get the time to fully evaluate or get the full history, or if I'm getting bits and pieces, then I'm a worse psychiatrist. And I think I'm a worse like human being because I don't take into account everything. So yeah, I think psychiatry has made me who I am. It's kind of made me more patient, more thoughtful, way less judgmental because, oh my gosh, everybody has a story. Everybody has something that's going on. And as the old Pope said, who am I to judge? Right. So, yeah. So I think psychiatry has made me just a more chill human being.
If you don't mind sharing your journey to medical school, how did you get to medical school? What inspired you?
Yeah, yeah. So I've always been interested in science. I was a super geek when I was younger. Love science, love math, all those things. I became a pharmacy tech in high school. I was working at a pharmacy chain called Eckerd, and then when I went to undergrad, I did all my pre med stuff, and I just liked the idea of helping people not feel bad because growing up, we didn't have a lot of money. I don't even know that we had health insurance. I don't remember all the stuff back in the day. But yeah, my journey into medicine was I want to help people feel better. And then I did like being in charge of stuff. So I've known since I was really little that I like to like tell people what to do. And so and not be told what to do by people that I don't think are very smart. Wah, wah, wah. So yeah, so I said, I learned it the hard way, but I eventually started my own practice and did my own thing because of it. But yeah, that was my original journey, and then I loved the fictional doctors growing up. So like Doogie Howser and Dr. Crusher on Star Trek. Those were like some of my idols growing up.
Yeah. Yeah, that's amazing. And I asked because in your introduction, it just says right there that you rose from poverty and became a
Mhm,
physician. That's just, I think there's a lot of power right there.
mhm,
Uh, and I'm so glad that you agreed to do this because I feel like we need to show also young Black men that this
mhm.
is a career. They need to come in because unless they're there, it's hard to treat other Black men, right?
100%. Yeah. The number of times when I go into a room, especially during residency, but I go into a patient's room and they look at me like a black male patient will look at me and be like, "Oh my God, you're my doctor." And I'm like, "Yeah, I'm here to take care of you." And it's such an honor. And then vice versa, to be able to sit in boardrooms and morning reports and, chambers of commerce meetings and be the only black dude in the room and be able to say, hey, this policy, this thought is not, we can't extrapolate that to everybody. How about you do X, Y, and Z? That's a very powerful thing. So yeah, I love it.
Yeah, no, I'm just honored and thankful that you just agreed to come and talk to me on here. And it's like interesting because in my child psychiatry conference, annual conference every year when I go, there are several Black women psychiatrists, but
Mhm.
I've only ever seen one Black child psychiatrist that comes. I'm assuming that he's the only one that shows up to the conference, but there's only one. That in however thousands people are there, there's one. And so that it's sad. And I wish that more people were given the opportunity and encouraged. I think it's not even so much encouraged, right? If you
Mhm.
believe you can, then you will, right? And I
100%.
think that message is so important as well to put out there.
Mhm.
What do you think about all the resistance that we have from inside the field and outside the field to be called listen physicians or just overall the resistance to psychiatry?
Yeah. So it's very disheartening. So like being in some of these Facebook groups is like literally like kills my soul because I see doctors giving up before they even try. I see doctors signing up for things because they're afraid. I see doctors willing to be put down and kind of ruled over because they don't feel like they have the power to speak up. So, for example, and I know again, controversial, I did the triple board program at the University of Kentucky. So I did Peds Psych and Child Psych, which is 5 years. And I tell people all the time, or I'll ask people, do you respect a general surgeon? And they'll say, absolutely. And I'll say, how much do you think a general surgeon should make? And they'll go, I don't know, $500 million. And I go, great. Their residency was the exact same length as my residency. So then why should I accept a third of what they make and what they generate just because because of the term psychiatry when our training is exactly the same length. And most times that'll get people to go, oh, I never thought about it. Now, unfortunately, the people um, who really believe that inequality most times is are other psychiatrists. They're literally like, well, we're not worth as much as a surgeon, which just blows my mind because I'm like, y'all, we are literally helping people save their lives, change their lives. Yeah, I understand. Yeah, having a surgery to get rid of an abscess or cut something off is very powerful, but the stuff that we do affects life over 70 years. Yeah, so I don't like what's happening in our field. I wish our attendings and our training attendings did a better job of inspiring the next generation. I think that, and then the folks outside of our industry, unfortunately, I think do a really terrible job of acknowledging how awesome that we are. So, yeah, that's my soapbox.
Yeah, no, but it's true. It's true. So tell me about your practice, because now that I know that you're triple boarded, so what is your
Yeah.
practice like?
So what I do nowadays, so when I first started, I finished residency and fellowship in 2011, and then I started private practice in 2014. It is way too difficult to try to do peds and psychiatry all at the same time, just because of the infrastructure investment that it takes to do pediatrics. And so I mostly just do child psychiatry. So all outpatient, all direct pay, so no insurances. I have 5 other doctors now working with me in my practice, and then yeah, we kind of cover the gamut of different types of diagnoses and situations. Most of my practice for me is all kind of reactive attachment disorder, ODD, IDD stuff, autism. Yeah, any kids that are throwing fits, that's my specialty. So yeah, but
So
yeah, but it's really great. And then I do miss consult liaison. That's kind of my second favorite subspecialty in psychiatry, but it's too hard to do.
yeah, yeah. I hear you on like your second interest. That's what I'm doing right now.
Really?
Like the
Yeah.
inpatient, I have to get that fixed. I'll get a
Yeah.
consult here and there. I'm not a huge consult fan. Some of the consults just drive me
Mhm. Yeah.
because because it's just like, okay, you didn't need to call me on this, but I've gotten used to where I'll be like, okay, I'll come see your patient because I'm just like, okay, again, the overall in medical school or even after, right? Hospitalists or any other emergency room doc, they just don't know enough about
Yep.
psychiatry. They have just not gotten enough training.
Correct.
And again, that just speaks to the value of us as psychiatrists that, you know, you have a delirious patients, and how many delirious patients have you seen? But you still need a psychiatrist to come help you. And that means
Mhm.
that our value is that much. And unfortunately, I feel like overall, even in the physician community, I feel like that's not,
Yeah,
I
it's
don't
not
know,
appreciated. Yeah.
yeah, the procedure, I guess, mentality that if you're not
Mhm.
doing an actual procedure, right, which we're going into the realm of procedures now, like TMS is approved for children, right, for adolescents. So we're going that way. We're coming up with new things, and
Yeah.
there's data. I don't know if you do any TMS or.
Yeah, so I'm a less is more kind of psychiatrist. So I do
Mhm,
appreciate so because of how I trained, because
mhm,
at
mhm,
University of Kentucky at the time, we had a lot of kind of white-haired older psychiatrists who didn't have access to even these, fancy new medicines, second generation atypicals and blah 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 blah. So they just had to make do with therapeutic interventions and then time. And so they taught us a lot of those approaches and techniques and that kind of pedagogy and philosophy. And so I always come from the perspective of less is more. I appreciate
mhm,
ketamine. I appreciate TMS. I appreciate Spravato. I appreciate ECT. I appreciate all those things. But I'm going to almost always continuously work to try to do as much as possible
mhm.
without the kind of invasive stuff. So.
Hmm. Yeah, I think that University of Louisville is very similar to the program that you trained at. I mean, they're just right there next to each
Yeah.
other. I trained at University of Louisville. Same thing. We had
Mhm.
our psychopharmacology attending that taught us all of that. We had our psychodynamics. We had our
Mhm.
CBT. We even had a psychoanalyst that was
Mhm.
partially retired, and so but he was still, teaching us and doing, didactics and stuff. So I feel very lucky. I'm very thankful to have trained at a program where it was psychotherapy heavy. And that's what I did look for as well when I was applying for residencies and training.
Mhm.
Same thing with my child psychiatry. My attending's very psychodynamic, psychotherapy oriented. So I got a lot of training in that. So yeah, I wish that more programs was like that. And I thought that more programs were, but it doesn't sound like they are.
Yeah, which to me makes me go, what in the world are we doing as far as like accreditation? Like, why are we turning out psychiatrists who don't know this stuff? It just blows my mind.
Yeah. Is that part of the, how should I put it, Listen Physicians campaign pitch? What would you call it?
Yeah, so yeah, and that's exactly what you would call it, a marketing campaign to put the term "listen physician" um, out into the public sphere. I would say yeah, because so it used to be. I don't know how old you are, but I was in the group of psychiatrists that still had to do oral boards. Like, and we didn't do the boards during residency. We had to like go off and do oral boards separately. But because of that, there's kind of this. I don't know. There's an incentive to get really, really good at presentations and to see everything because you were being tested and evaluated by attendings that were not your attending. So they had no idea if you were actually good or not. So you had to really, I don't know, there was a just different incentive to make sure that the candidates from wherever your residency program were wherever your residency program was to be really good at presenting and that sort of thing. Well, now they've changed all that, and the oral boards happen during residency in like two or three different phases. And so, one of the hiccups with doing it that way is you don't have an external validator. You don't have an external team to swoop in and go, hey, your residents are not doing what other residents are doing because it's all in house. And I think that actually hurts us. So I don't know. I'm not advocating for oral boards to come back because they sucked and were terrible, but it gives you one more way of making sure that you know and can do what you're supposed to know and do.
Yeah. Yeah, no. So I'm not sure if it was the same or not. I'm a late bloomer. I started residency in 2016, so we're probably the same age. But like, I did research in between, and yeah, late bloomer. That's what I call myself.
Nice.
But it's we had where we did have external examiners come and they would observe us do the entire interview and then we had to present. We did that in child as well, but in child it was internal only. But I
Mhm.
think that's just because there's not enough child psychiatrists to invite, especially because the programs are so far apart. And I was in Gainesville, Florida, of all places, so there's not that many outpatient child psychiatrists that would be willing to come and be examiners either.
Gotcha.
I think that's why we had internal, but in residency, yeah, that was, and you were afraid because you didn't know who you were getting, and there were reputations, and there was anxiety.
Yep,
And,
100%.
and some of my co-residents would come out crying, not pass that. They would
Yep.
have to do it again. And so
Yep.
I think we had to pass like, I had to do 2 in residency, and then I think there's supposed to be 3 for residency and 1 for fellowship, but you can take your 1 over if you're doing child. So I did 2 and 2. So,
Mhm.
but yeah, those were scary.
Yes, and it's again, I'm not a huge fan of like gauntlets and validating things, but
Mhm.
sometimes you do need a little something, something to motivate and make sure that people know and are doing what they're supposed to do. So, yeah.
No, I agree. And in child, I remember my attending, even though she was like my program director and good terms, but like when she told me right after this, why did you do that? It was just something simple like handing a tissue box over or something. But you need those teachers, you need those attendings, you need people that are going to point out, don't do this.
Yep.
And to this day,
100%.
I don't offer tissues until a patient asks.
Yep.
I'm just like,
That
I'm
is.
not gonna offer. So yeah.
uh,
All right. So advice to new psychiatrists that are entering the field.
Yeah. So the biggest piece of advice is start early. So if you're in residency now, I don't care what year, you should have a LinkedIn profile, you should have a website, you should have some kind of professional social media, you should be making contacts and networking. once you finish residency, do what works best for you. So a lot of physicians, a lot of our colleagues will get out and go, well, I need to make money. Totally fine, go do that. Some folks are like, I want to start a private practice. Fine, do that too. It's really difficult to do that nowadays. But yeah, follow your heart, follow your passion. And then the second piece is don't do this stuff alone. It will eat you alive. If you try to do anything alone, especially in the private practice space, you're sunk. It's just too, I don't know, it gets really lonely. And there's so many facets to running a business and trying to scale a business that are challenging. So talk to your colleagues, have a sounding board of colleagues for the clinical side, have a business coach for the business side. And then take care of yourself, eat right, exercise, and sleep. And so all the stuff that we tell our patients all the time. So those are my kind of warnings and advice for new grads.
Yeah, I think there's like a lot of new psychiatrists that come out and then they're asking about private practice that they want to start it and they're anxious and they've been discouraged to do that right out of residency or fellowship. I know you said that it is difficult coming right
Mhm.
out and doing private practice. What is your advice for them? Should
Yeah.
they do something else for a couple of years?
Yeah, it kind of all depends on the situation. So, like when I finished residency, I was unmarried and no kids, and so my ability to absorb risk and risky things was really high. And so it didn't matter if I didn't have money because I didn't have anybody dependent on me. For those folks who have families, if they're married or have dependents, it's going to be a lot harder to do private practice right out the gate. Now, let me give a caveat. Whenever I say private practice, I'm always referring to direct pay private practice. I don't understand how anybody makes a insurance based private practice work because the insurance company is actively screwing you over and makes it even more difficult to do anything. So yeah, so if you want to finish residency and do a private practice with insurance, knock yourself out. I can't really help you. I think ultimately it's not going to be successful the way you want it to. And so yes, if you want to do a direct pay private practice, the key is do a little bit every day and just keep doing that, and then get business coaching because I think that that's one of the best ways to ensure that your company stays financially solvent is you get coaching.
Okay. So, and when you say business coaching, this doesn't have to be specifically healthcare business coaches. Like, how
Nope.
does this work? No, okay.
Yeah, so that is the secret, and it took me a long time to figure this out. But the way to build a successful business is universal. And so, yes, you can have a business coach that is not a psychiatrist, that is not in the medical realm. I think it helps if you do, but the basics, the tenets are all the same. And so the key is find somebody that can meet you where you are. And then you have to do a little bit every day. I think that's where a lot of doctors, we get used to delegating. And when you're starting a business, you don't get to delegate when you first start. You have to do everything. You have to do the marketing. You have to do the operations. You have to do the finance. You have to do everything. So I think that's one of the biggest mistakes people make going into private practice right out of residency is they try to delegate too early.
Yeah, that's really good advice. Thank you. I'm taking pointers too for myself.
Yay, good.
Even though I've had my practice for a couple of years now, but like the business coaching part of it is like
Mhm.
we're not business people. And so that is very good advice. And I think that again, I'm going to bring listen physician back into this because I
Mhm.
feel like insurance companies also make it difficult to be a listen physician, right? Because
100%.
your medication management is where they're going to pay you, and then the more patients you see within the hour, the more you're going to get paid. And yeah, I didn't think I would ever do outpatient. I thought that I would just have a little therapy practice. But then I was disappointed by hospitals and those systems. But like, I do medication management, but on my terms. I don't see anyone less than 30 minutes.
Yep.
That's what it is. Even if like you're doing a quick med check, you got to talk to me so I know what's going on,
100%.
right?
Yeah, I'm the exact same
But
way.
like,
Yep.
yeah, insurance won't let you do that. Like.
Correct. And that's why I think, and again, this is going to be hard to hear, but if you're a true listen physician, I don't think you can take insurance. It just doesn't work. I mean, the that 30 minutes I think is a minimum. I'm just like you. I do a 30-minute minimum. If I need to extend it to 15 or 15, extend it to 45 minutes or 60 minutes or an hour and a half. I have that flexibility because I have a direct pay practice. But yeah, insurances, number one, insurances don't care about healthcare. They care about their bottom line. So it is not about care for them. And I wish that psychiatrists would quit enabling these really bad companies to do what they're doing, because that's what we're doing. Every time we go, I'm so afraid I want to sign up for Alma. I'm so afraid I want to sign up for Headway. I'm so afraid I want to sign up with Blue Cross or whatever. We're enabling the very thing that is hurting us and our patients. So I'm going to hope and pray that people who hear this message will believe in themselves enough and then get business coaching so that they can just go direct pay. Even if you're, charging $75 an hour and keeping your expenses down, do what you need to do to not endorse these companies.
And I feel like telehealth has made it a little bit easier to
Hmm.
start out. And that's how I started. I mean, I started a year was just telehealth. You have minimum overhead. You can get started, get your feet wet, and then maybe go get a tiny office even before you get a bigger office, you know?
Yep.
Like I think the first office that I had was, I don't know, $100 a month
Yep.
rent. So like it's okay. It's a small. It depends on how good you are. I don't think patients are worried about where you're sitting.
Correct.
It is they're more worried about how good you are and what you do, and you're helping them.
Yeah. If you give them value, they will gladly pay you for it. That's the other crazy thing. I was like, oh my God, people actually like just give me money. Yeah. If you do a good job, they will literally hand you cash. It's the most insane thing. It's so fun.
Yeah. Yeah. And that's how it was, right? I really think about a lot of the times about how it must have been during Freud or Carl Jung. Like, how were they practicing? How did they charge patients? And I've looked into this because I thought that that was something important because we're doing essentially, maybe I'm not doing 100% psychoanalysis, but close enough, right?
Correct.
That's what we're doing. So I really was curious that how did they do the billing? Obviously, everyone has to make a living.
Yep. Yeah. And it's all direct. I tell people all the time, healthcare should be like buying water. So if in this country, if you want a glass of water, there's a communal version where we all pay into a pot to make sure that the infrastructure is there. And then you pay per use. And if you want super fancy water with bubbles in it, you pay even more. If you just want tap water, you generally pay less, but you still pay. And the key is that you have that public infrastructure with a per use uh, fee attached to it. So there's no magic to this stuff. Healthcare should be the exact same thing. But I'm out there beating the pavement, screaming about it. We'll see if anybody hears me.
Yeah. So the idea is that take it to other physicians first.
Mhm.
What about just the general public? I feel like social media, when you throw a term out there, it gets taken up. How can we do that? I'm sure your business coaches, I want to get in on this so I can do the same, throw it out there. I really like the term because
Yeah.
that's how I feel I am.
Well, this podcast will be the first place audio wise that the listen position is. So there you go. You
All
get the
right.
first dibs. Woohoo!
I'm going to hashtag it everywhere.
Okay, perfect. You should. In my brain, it would be kind of multi-pronged. We do the academic route. So if we can get some academic physicians, folks who are working with the future of medicine, and we get them saying listen physician. And then we get the private practice folks using listen physician because it is a marketing hedge. There are lots of nurse practitioners out there. There's lots of physician assistants out there. And for the doctors who know their value, for the psychiatrists who know their value, if we all stick together and use listen physician in our marketing and it ties us all together, it lifts all boats. So that's the one prong. And then the last prong would be those psychiatrist influencers. So those folks who are on TikTok or, Instagram, blah, 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 YouTube, who have big followers. Most of their followers are like public facing. And so if we can do a concerted effort with all three, basically for, I'd say, a sustained maybe 6 months of talking to the residents and the academicians, talking to the private practice folks, and then talking to the influencers, I think we can get it to stick. I am not optimistic that the traditionally employed psychiatrists will take this up because they have these are the folks who are getting beaten down in the health system and seeing 80 patients a week or whatever it is. So I'm not convinced that they're going to be helpful. So those are the three markets that I'm going to try to corral together to do a sustained at least 6 month marketing campaign.
All right, and we're gonna start with this one.
Yes, start here.
Yes, start here.
Mhm.
Um, all right. So, what do you see in a year, 2 years? How do you see the profession of psychiatry? What do you see people are gonna like have an impression of us psychiatrists?
Yeah, I think one of the blessings and the curses of COVID, as well as the increase in nurse practitioners practicing separate from us, and then just the slew of coaches and the slew of discussion about mental health, is that yes, there's more awareness and exposure in the mental health world than ever before. And yes, it will kind of sting a little bit for a little bit longer because there's lots of other people who are out there controlling the narrative. But if psychiatrists kind of band together, in a year, I would say that we will be the mental health experts. So yes, there's going to be lots of people running around saying mental health this and Spravato that and TMS this and all the things. Ayahuasca that. I'm kidding, but when it comes down to it, I'm optimistic that when all of the fads have come and gone, when all of the chips are down, people are still going to say, who is the best trained person for my mental health? And I think they're going to look to psychiatry. So the key is right now, I'm just going to work with you and work with other folks to lay that foundation, kind of silently in the background while all these jokers run around and do what they're doing. So that, yeah, a year from now, when people say, I really need somebody who is good and trained, we'll have a whole slew of psychiatrists going, I'm ready to help. So
Absolutely. So one of the things that I personally am curious about is what about patients that can't afford therapy from you but still reach out or help? Do you do pro bono? Do you do like a sliding scale? How do you like what is your approach to that?
yeah, so my approach is that there's always someone available. So I don't do sliding scale. I don't discount my fees. I don't do any of that stuff. I instead get them to a person that fits their particular situation. So yeah, and we get lots of folks who say, "Oh my gosh, your fees are too high," and I say, "I understand that you want to use your insurance. I understand that you would like something that's more in your price range. So I will find a person or refer you to a practice where that's the case." Now, on the flip side, when I'm out and talking to people, I remind them all the time that mental health is an investment, right? So if you invest in your car, you invest in vacations, if you invest in coffee, if you invest in all these other things, um, you can invest in your health, your mental health, and is another way of asking it is your mental health worth only $20? Because if it is, then okay, I can find you somebody that'll do that. Is your mental health worth $500? Yes, then great. I can help you with that. And folks who pay that type of money, they are invested and they follow the treatment plan and they get better and then they move on with their lives. So I know I'm not the perfect fit for everybody, but the folks who like my style and my approach, they get better faster. So there you go.
Yeah. No, I agree with you. I've done pro bono a couple of times, and a lot of the times what will happen is that they stop the no show, and it's just like, okay,
Correct.
well, you're not paying, so you don't see the value of my
Yeah.
time, and so or your own health, right? So
100%.
um yeah, and I think I'm with you on that, that it's an investment and it's just essential, not even just an investment, like it's essential for everyone to at
Mhm.
least have some kind of idea of how to take care of their mental health. And you're only going to learn from listened physicians.
Yeah.
Yes.
Love it.
Anything else that you would like for, our listeners to know about rebranding psychiatry? Any last
Yeah.
messages that you have?
Yeah. So last messages is yeah, you are what you eat, you are what you think, you are what you say. So be very purposeful in how you say, what you eat, what you do. So it's gonna take a generation to get this term to change, but we got to start somewhere. So let's go ahead and start now.
I like this approach. And so if someone wants to get in touch with you, how do they get in touch with you?
Yay. So I do have a website, drbriandixon.com. So DrBriandixon.com. And then I'm on LinkedIn. I cannot stand most other social media platforms, but I am on them reluctantly. So if you Google my name and those things will pop up. But the easiest way is just email me. Just go to my website. And then my direct email is brian@drbriandixon.com. So yeah, give me a shout.
All right, awesome. It was so wonderful having this chat with you. Again, I'm
Yeah.
very grateful you came and talked to me. And hopefully we can get this out there and we can get the listen physicians out on so everyone knows who we are, because I agree. People don't understand what psychiatrists do. You can introduce yourself as a psychiatrist and people don't know what you do. Or they'll
And we
say
will
that,
change that together.
yes, yes. Or they'll say,
Mhm.
oh, so you're analyzing me right now.
Yeah, and
Well, yes,
instead,
I am. So I'm
mhm,
listening.
correct. Exactly. Yep, I'm listening to you. There you go.
Yeah. Thank you so much, Dr. Dixon. I appreciate you joining me.
Thank you so much for having me.
Before we close, I always ask, how are you really doing? Thank you so much for spending this time with us on How Are You Really? If something in this episode spoke to you, send it to a friend, leave a review, or follow the show. It really helps. Until next time.